everyone. Okay, let me do a couple of mic checks. Can you guys hear me in the comment section? Can you say yes or a thumb up right quick? I see Liz is on. Yes, they said they can hear me. Yes, thank you, thank you, thank you. Hey, Liz.
Hi.
No, okay.
Oh.
Okay, good. Okay, I'm trying to make sure the cameras and I'm okay. Am I too loud? Because I can bring my volume down.
No, I think it's good. I don't know how is my sound?
You're good. You're good.
Yeah. I think they both sound good then.
Okay. Everyone that's coming in, the participants, everybody, y'all can hear fine before we get started. Okay, everybody said yes. So, all right, we have people are starting to join, so we might as well get started. Okay. And as people are coming in, if you're missing anything, you'll get the replay. Everybody will get the replay, okay?
Good.
So, anyways, thank you, Liz, for joining me today
on
this Sunday. I'm going to try to turn you up just a tad bit, okay? Sorry if y'all heard that. Okay, all righty. So, hello, everybody. My name is Kimberly Ellis, and I'm Kim E, the Diabetes MP. If you all follow me on Instagram, my handle is the Diabetes MP, and I also have a YouTube channel, Kim E, the Diabetes MP. And so, what I wanted to do tonight is talk about just clinical pearls for the new grad nurse practitioner, okay? And the reason why I wanted to talk about this is because, good, you said loud and clear. Am I too loud? Please let me know if I'm too loud, okay? Because I am from the South, so we do talk loud.
And I talk fast, so it's
fine. So anywho, for the month of April, I've really been trying to lean into just new grad nurse practitioner students in light of everything that we've been going through. It's kind of throwing a monkey wrench into everybody's plans. And, it's already stressful as a new grad to have to graduate to get through school, but then you go into the fact that you may have classes that are all virtual now. You may not be able to interview like you would normally do. Like everything is so uncertain. And so I've teamed up with a lot of different nurse practitioners just to kind of bring resources for everybody, to kind of lessen those anxieties. So today we want to talk about clinical pearls. And Liz, I'm going to let you introduce yourself because that's your thing, girl.
Sure. So I'm Liz. I'm a family nurse practitioner. I have Real World NP is on Instagram and YouTube, and a website is a educational platform basically to help new nurse practitioners kind of ease that transition to practice through sharing clinical pearls, practice tips, things like that. So I have weekly videos, and then I also have a course and hopefully some other courses coming. But yeah, and then I do some one-on-one mentoring as well.
Okay. Now, Nikki said that she can't hear you.
No, shoot.
Was it me or was it Liz? Kim or Liz? I think you can hear me now.
Oh, shoot.
Okay.
Let me see if I can turn it up a little bit or something. Can I do
that?
Or?
I'm telling you guys, we're trying to navigate this technology. We're going to do it. Okay. They said they can hear us both. They said they can hear us both now.
You can hear both. Okay. I wasn't sure what side the microphone is on, so
okay.
I fixed it. It's backwards.
And everybody heard, you heard her introduction. Okay. So, okay, good. All righty. So, first off, where is everyone located? What states are y'all located in? And then I also want to know, Arizona, I want to know if you guys are students or new grad nurse practitioners. So that'll help us be able to focus how we speak. New grad working for 2 weeks. Okay, good. Nice. Good. Okay. Paris, Texas. Go Texas. Just finished FNP program. Okay. Very, very good. Okay, great. That's really good, guys. Okay. Fort Worth. I'm in Dallas. How are you doing, Tisha? So, Okay, good. So, Liz, when you are dealing with our audience, they're students, many of them are brand new grads. What are some things, what are some advice points that you like to give new grad MPs?
Absolutely. So I think the first place to start is like when you're thinking about like with your first job, it will happen. So just kind of give yourself a little break. It's okay. Some deep breaths. I mean, first thing is boards, right? And once you pass your boards and you're thinking about the jobs, once you get your first job, I think the main thing for me is that I recommend finding a job that is a good fit for you and trying not to take the first available. I mean, it can be tempting and there's different philosophies about that, but finding a supportive work environment that somebody will like not every like the ideal situation is that everyone has a mentor, right? That they have somebody. I define as an ideal situation as somebody who is assigned to be your mentor. You meet with them once per week for 30 to 60 minutes to go over your questions, and they can be your point person that you talk to.
Mm-hmm.
That doesn't always happen, and you kind of sometimes have to ask for that
Mm-hmm.
yourself and just kind of advocate for yourself of like, listen, can we do that? And then I think
Mm-hmm.
the other thing is talking about a ramp up schedule that's appropriate, because I
Mm-hmm.
think it depends on the setting that you're working in. If it's with only physicians, if they've worked with nurse practitioners before, if there are a lot of nurse practitioners, like I think that's one of the traps that definitely that I see is that people will be like, okay, you're going to see 30 patients tomorrow. That doesn't happen
Mm-hmm.
commonly, but I think that it's not normal. And sometimes you do have to advocate for yourself, talking about as you're starting like what the plan is. And I think most people, if they're hiring a newly graduate nurse practitioner, if they've worked with nurse practitioners before, they understand that.
Yeah.
But if they don't, then like having that conversation of like, okay, for like the first 3 weeks you're going to see one patient per hour, and then or a month, and then the next month you add one patient every single day or every single week or something like that, just kind of figuring out what works for you and then just checking in. I mean,
Mm-hmm.
that's the main thing, is just making sure that it's like a kind of an ongoing conversation. And I think like the third thing is that just resources, like knowing what your resources are. I personally am a huge fan of Up to Date, and I paid for it out of pocket. Like it's like $500 a year, but it was just, I was on it constantly and I still am. So
Mm-hmm.
whatever your resource is, even if you don't go for Up to Date, and I'm not sponsored by them or anything,
Mm-hmm.
I'm just obsessed with them. But I think those are the main things, is like a
Mm-hmm.
good working environment that's supportive and communicating your needs, and
Mm-hmm.
understanding that it's okay to, if you're overwhelmed, to ask for help, and to like make sure that it's a good fit for you.
Mm-hmm. Something else, you had mentioned something that made me think of something. When I was in school, we were having such a hard time finding preceptors. And this thing about paying for preceptors, that we didn't pay. But then I'm hearing that people are having to pay for preceptors. Now, one thing that I will say that my professor told us is that once you make it, turn around and reach back. Okay,
Mm,
someone had to
mm,
precept you. So once you get to a place, and typically after your first year, look to precept someone.
yeah,
Okay, and it's a dual thing because that goes towards your continuing education
it
hours.
does. It
It
does.
does. And they give you, it's not hour for hour, but you have to have so many and they'll give you like a big chunk. Once you hit that threshold, I think it's like, I can't remember, but once you hit the threshold, they'll give you 25 hours of contact hours.
Mm,
And so, like, I precepted probably 2 or 3 students and got like well over like 200 hours with
that's
them,
awesome.
because one had to get like 112 with me. But I think like the AAMP, and I don't know about the other board, but I know with AAMP, once you hit a threshold, they just give you the chunk of 25 hours.
Yeah.
And so it works in your favor. It really
Yeah,
does work in your
it
favor.
does. And I feel like one of the things that new nurse practitioners, there's so much imposter syndrome, and that lasts for so long.
Mhm,
Just this feeling of like feeling fraudulent and feeling like you're fooling everybody,
yes.
and that they're gonna find you out and they're gonna take away your license. You're just feeling like, what am I
Mhm,
doing here? And I think that lasts for a really long time, at least through I don't know. Everyone's different, but I think especially like hitting a year mark, I think there's definitely like a every day and week and month is better, but hitting a
mhm,
year has a big difference in terms of feeling more competent. And I think that
mhm,
people, when it comes to students, I'm definitely a huge proponent of having students because again, like paying it back, right? But also like it helps you as a clinician. Most people feel like they're not ready and like, what do I have to offer to a student? I only have a year of experience or whatever. I actually was kind of thrown into precepting a little bit sooner than I was ready for because of a staffing situation, of somebody leaving. But it was fine. And actually, when I was a student, I loved being with people who had less experience because it was like a snapshot of what the future is going to be like. And it also helped me feel less overwhelmed as a student because you kind of see how much looking up there is on the job and how much learning there is. And this is all normal versus when you work with somebody who's been in, like I worked with a PA who was a PA for like 10 or 12 years. And it was like really intimidating because I was like, I don't know all of this. But when I was with a year of experienced student or a nurse practitioner, it was really helpful.
Okay, now we got a question here that said, I took boards in December and I'm having a hard time finding a job as everyone prefers experience. Could you offer some advice on that? And also Kevin said he's having the same problem. You want to take that first, Liz?
Yeah, I mean, I love everything nurse practitioner, but I definitely focus on the clinical stuff a little bit more than the job stuff. And our friend Amanda definitely is on that. But I and so something that she talks about that I found myself is that when being a nurse practitioner, the job postings are a little bit different than like nursing postings because like nursing postings, you can kind of like go on Indeed and there's an RN position at Mass General Hospital for this amount of money for this level of experience. And it's just very like cut and dry. And like for nurse practitioners, it's just very different because there's like this hidden job market is the way that she refers to it. And it's kind of like there are a lot of jobs available that are just not posted in that way. And so it kind of comes down to identifying where you want to work. And I'm a fan of cold calling in general. Like it's a terrifying skill, but I feel like just getting over that, it helps. But like reaching out to clinics, like I have a clinic that's close by in my home, in my work, the town that I live, and I reached out to them and they weren't hiring on paper. But if you talk to them and you talk about your experience and like, oh, well, you know what, we're thinking about hiring somebody soon. We're just getting the budget together. And that's how you kind of like work around that. And so like, it's intimidating to do that. And you might get a lot of hits in terms of like, you have to reach out to a lot of people. But if you can, customize your resume and customize your cover letter and understand the company that you're reaching out to and like think of yourself as becoming part of their family, because that's kind of what it is. Like you're going to spend all your time with them, right? I mean, if you're going to stay there for a long time. And so how are you a fit for that particular job and not just like spamming your resume? Like not to be disrespectful by saying that, but like that's how I felt sometimes that's how I feel sometimes when I send out my resume. But it really, especially having hired somebody in my own business, like it makes a big difference when somebody actually pays attention to my company, what I do, because I care deeply about the people that I serve, right? And so if you think about a clinic, like they dedicate their lives to this clinic, especially the people that run it, right? And so like for you to walk in and be and say like, oh, I understand your company, like I see what you're doing here, like that kind of thing, I think is really impactful. It makes a big difference, especially if you don't have experience.
And then also, as a new grad, I definitely got a lot of no's, but I also got a lot of yeses. And I also got a lot of delayed yeses because I interviewed with a hospital system and they had multiple clinics. And there were certain clinics that needed a provider right then, but there were some that needed a little later. And depending upon the physicians and the providers there and how high paced, fast paced they were, some of them needed somebody who was able to hit the ground running. But then some of them were a little slower where they're like, okay, well, we have time to train a new grad nurse practitioner. And so I remember interviewing with the HR woman, and because she liked my personality, she kept me on her short list when anything popped up that she felt like I would be a good fit for. By the time she called me, I had already accepted another job. But just putting yourself out there, like Liz said, people never forget you. And then you also want to make sure that you're sending like your follow-up thank you notes and you're sitting yourself out like that. And then also thinking outside of the box. There are so many areas I think sometimes we can get so caught in like, I'm going to be a clinical nurse when you can also work for insurance companies. A lot of insurance companies, they have clinics now. Okay. And so they're kind of they are staffing it with physicians, and they're staffing it
Mm,
with nurse practitioners. That's what WellMed is. That's owned by United Healthcare. That's the
mm,
company I work for. And that's a
mm.
clinic. It's a clinic.
Yeah.
And so they're owned by Optum. You know what I'm saying? And so going and looking at different outlets like that. Now, someone said, let's see, someone, because I'm trying to keep up with the comments. Precepting physician. Yes, I did half of my clinicals with physicians. I did my pediatric rotation with a pediatrician, and I did my OBGYN. I did my women's health with the OBGYN. I rounded with them. They didn't ask for a dime from me. I used to go to the hospitals with them, and I was even in surgery. That's how I did my first suture, was on a woman getting a C-section.
That's
That kind of dates
amazing.
me. I don't think they sew people up anymore. But I mean, like, so yes, and they were my best. They called me higher, and they wouldn't let me, like, I had to start using my brain a lot more. It says, would you suggest volunteering at a health clinic or similar service? Yes, yes. There are a lot of free clinics, and that's experience, whether you get paid or not. That is experience.
Yeah, I think the main thing to think about is like malpractice insurance, if they're covering
Yes.
you for that in terms of your own liability.
Yes, and most of the times with liability, your employer will take care of that, and a lot of nurse practitioners carry their own in addition.
Right,
You
right.
got to kind of learn. You'll learn a little bit more about that once you've been a nurse practitioner for a while. So just, yeah, like what you said, I would like to specialize in dermatology. Okay. No, it's not a long shot to apply for derm. You have to realize it's really up to the people that are hiring, because sometimes they want somebody who is moldable. And when you come in with a lot of experience, you got a lot of, well, we used to do it. Well, that's not,
Mm.
this is a new clinic, you know?
Yeah.
So they like to have people that are open, quick learners, if you can convey that. What do you think, Liz?
Absolutely. I was just going to say, especially if you've had the opportunity to do a specialty rotation, that would be
Mm,
amazing to highlight on your resume, being like, listen, like I'm brand new and I'm definitely like, I want to learn the way that you guys do things, but having some foundational familiarity with like what it's like there. And you can like highlight on your resume, like, hey, I've already done punch biopsies and shave biopsies and like whatever, like
mm,
cryotherapy or like whatever procedures, that you've seen, and highlighting how many patients per day you were seeing by yourself. And that kind of like speaks to like, okay, like how quickly is she going to be able to start versus has she, or he or she, sorry, I didn't see Brittany, has she been in a derm clinic before? Is she seeing patients on her own yet? Like demonstrating that like you were be able to kind of pick it up quickly kind of thing.
mm.
I mean, it is
Yeah.
hard being a new grad with no experience, but there are definitely ways that you can kind of
Mm,
highlight that and develop those relationships, right? And like you talk to somebody at the front desk, or you talk to talk to the office manager, or give your resume to them and understand their company and like what they're going for. I don't know. It's like it's if you understand them, you can kind of develop relationships and follow up. And I love what you said about like not the delayed response. So I applied for a new job. I have about almost 5 years of experience, and at the time I had about 4, and I applied for a new job, and I was like kind of heartbroken because like I was like, I have so much experience, I'm so independent, and I'm not hearing back from any jobs. And it took months. And it's like it's not personal. Number one, it's never
yeah.
personal because HR
Mhm,
is just backed up.
mhm,
And like as soon as I did a couple of interviews and I accepted the job, and then I got a flurry of people who got back to me, and it took 3 months to get back to me, even with experience, ready to go. I'm ready to leave. Like I've left my job. So I think
mhm.
keeping that in mind, that it's just sometimes the systems are just not ready. They don't have the funding for the position. They don't have the HR staffing. You have to interview with. It's just there's a lot, and there's the credentialing. There's like a whole piece to it. So
Yeah.
not losing
Yeah.
hope with that.
And that's the back end of it. And that's what we don't really deal with as registered nurses.
Mm-hmm.
It's a total mind shift. It
Yeah.
really is a mind shift, because now, though we're nurses, we are providers, and we're lumped in with physicians. You know what I'm
Yeah.
saying? we can contract ourselves out just like they contract themselves out, you know? And so it's not like we're like the herd anymore. We're not the nurse herd.
Yeah.
We're like providers now. And it's kind of
Yeah.
a weird space for us because we're not used to that, but you have to start shifting your thinking.
Yeah, because
Okay.
like when you apply to be a nurse, like if you already have your license and your background check, that's kind of like all you need. And then you can start tomorrow. But for me, if I change clinics, they're investing in me because I talked about on the video last week I did with Amanda talking about the credentialing process, but basically you have to, every insurance company that you submit billing for, you need to be credentialed with. And that's crazy. Every single insurance that comes to your clinic. And so for my new job, like I have like Mass Health or the Medicaid basically, because I'm in a community health center, but like, and if you're in a private practice, you're Blue Cross Blue Shield, Harvard Pilgrim, that takes a long time. And like, that's invested time and energy and money. Like they're investing in you. It's a big decision to hire you.
Yes. Now, I do want to get into some, I made a little bit of a list of just some practical things that I could think of off of my head. If I could go back and tell new grad Kim, you know, to kind of ease her fears.
Yes. I have so much compassion for a new grad Liz.
Yeah, there was a lot that I would have said, just give yourself a break. That's where I start there. Okay.
Yep.
But I'm going to run this off. If I'm going to run it off, and if you think of some as we go, and it's just 4 quick ones, okay? And then you can give your feedback on them as well, and then we can take questions, okay? So first off, establish a rapport with your patients. And the reason why I say this is that one of the things that'll help ease your anxieties if you can start getting results from your patients, and getting results from your patients is having them to trust you first. I think sometimes too many new grads come in and we have all the facts, but we forget our heart that we got at the bedside. You know, that is why nurse practitioners are the last 8 years, we're like the most trusted profession because we actually stop and listen and we actually act on what's being told to us. So our bedside manner is our strength. Okay, so we know if you've worked any time at the bedside at all, you've had to do clinicals, you know how to break the ice with people, you know. And so establishing that rapport, you will literally have somebody who would do anything for you. I mean, I hate to say it like that, but like you want them to adhere to your care plan.
Right. You want their buy-in for sure.
Yeah, they need to understand that you care and that you're not just they're not a number. I have heard so many people say, well, they're only prescribing this medicine because they're getting a kickback from it. And now at one point in time, people did do that, but they don't do that anymore. But you can't tell your patients that. They don't know that, you know. And so you want to convey that you care and that you're coming from, yes, scientific research, but you're also looking at them as a person as well.
Absolutely. Yeah. And like on that note, like I think that like one of the things is that like I had a really hard time with, and my students I think have a hard time with too, is that like, especially with diabetes, right? Like there's this whole like 1, 2, 3, 4, 5, 6, like all these things that you need to do for them. They need to be on ACE, they need the microalbumin, they need to check their feet, you need to educate them about their feet. It's like a lot, right? And that's just like a check-in. That's not even like a new diagnosis, right? And like I think that like it's we need to acknowledge, like in terms of that building rapport, is that people are like, they're going to go home and live their lives, and it feels very final and very serious, and it is. But at the same time, like even if you did that whole laundry list of all the things, you checked all the boxes, they're going to go home to their regular life and they're going to come back in 3 months. It doesn't feel like they're going to come back in 3 months, because the first time you see somebody, you say come back in 3 months, it's like, oh my gosh, are they going to make it? At least that's how I felt.
Yeah.
But like that will come with time of like, okay, we're going to talk about urine microalbumin today, because they're going to get overwhelmed and they're not going to come back. At least that's what I experienced, is that I would throw things at people because I needed to check all my boxes, and like they were like, whoa, I don't like her.
Yes.
She stresses me out. Or they come back and they're like, yeah, I just didn't do any of that. Sorry.
Yeah. Victoria said, I'm also afraid I'm losing all of the knowledge that I have gained while in school. since I'm not currently practicing, any tips on keeping that info fresh in their mind while awaiting? So Kevin said, keep up with journal readings. That is good. Also, take advantage of online courses. Take advantage of CEUs.
Yeah.
Take advantage. Everything is online. I know. I shared it on Instagram. InPace is one of the organizations that does continuing education hours starting Tuesday. They're going to be doing $10 Tuesday. Their
Ooh.
conferences are not $10.
Wait, say
Okay,
that again? $10 Tuesday? That's amazing. I don't
$10
think I saw
Tuesday.
that.
Yes, they're
Amazing.
offering every Tuesday one of their online courses for
Whoa.
$10.
Whoa, that's huge. And Pace is a great organization. Yeah.
Yes, um I've gone to their conference, and it's great. It's great. Like it's not like AAMP, because AAMP is a production. I don't know if Liz, if you've ever gone to the AAMP conference, but
No.
it is a production. Okay, every NP in the world comes.
Wow. That sounds
But in
crazy.
case, we're all in one room and we're doing the same courses all day. And you get, I think I just was looking at my continuing education hours. I think I got like over 30 over a
Wow.
4 day span.
That's
Half
awesome.
of them were pharmacology, half of them were contact hours.
And the
And
farm
so,
is great too. It's hard to get.
yes, they gave 25 farm.
Wow.
And so like them having something online, in pace $10 Tuesday starting April 21st. I saw them post that online, and everybody's going virtual. So, keep up with that. Like I have lots of videos online. Liz has videos online. Also, Nurse Liz has lots of videos online. Registered Nurse RN has a lot of stuff online. Like there's lots of organizations and nurse practitioners that have resources and other things that are going to be coming out soon. So just take advantage of that stuff now while we're in the house. Really.
Absolutely. And I think sometimes like it's hard to apply them when you're not seeing patients, but like that passive learning of like, okay, this might be important someday. When you start seeing patients, you'll remember back to those things, even if it's not immediately sticking right now and it feels like information overload, especially if you've taken your boards already. I mean, just kind of having like a fun, casual, I'm interested in learning approach. And then it's not as much pressure, you know? And it also comes back, right? Because like as soon as you see your first patient, like I was on maternity leave for 3 months and I was like, I don't know how to do my job anymore. And I go back to clinic and I was like, oh, okay, I can do this. I can do this.
Yeah.
So it took a little while, but it comes back.
Yes. Now, Carolyn is asking about going to doing mission work, third world countries, and providing care there to various organizations. Should you bring this up off the bat? Wait 5 years. Honestly, probably not. Don't wait to bring this up. You can actually negotiate that into your contract. They don't need to know necessarily what you're going to do in your time off. You can just negotiate your time off. You just, you can mention that, like, I do X, Y, and Z. Some organizations that you work for would actually like that. That would actually make you look good to them, and so maybe would even sponsor you to go. I interviewed with a pediatric clinic where the husband and wife, where were they from? I can't remember. But they would go for about 2 months back to their home country, and they would do that. I work with plenty of coworkers that are from other countries, Africa, Ecuador, and they do the same thing. Every year they do a mission trip back to their home country. So, you can do that, and you can get funding for it as well. If we aren't getting experience in clinicals doing procedures, do you have companies that you would recommend to do a class through? Yes, there are lots of nurse practitioners that offer skills classes.
Yeah.
Um,
Advanced practice prep, I think, is one of them. I did
yes,
one of those. Yeah.
yes, and there's a couple that are in Facebook groups, and they're always posting. I
can't remember their name.
I can't remember their names, but like if you're in like some of the big nurse practitioner groups, if y'all are not in Facebook groups, you need to get into them. That's a good thing because you get to network with people.
Yeah.
And you get to see people put out continuing education hours, classes and opportunities, advanced. Yes, they said advanced practice prep. Yes. And there's a slew of nurse practitioners, our colleagues, that do skills labs. They
Yeah.
do them, and they have been doing them prior to the virus. They've been doing them online and live. So I mean, there's lots of stuff out there. My next tip is work smarter and not harder.
That's great. Yeah.
Now, I say that and I think about, like, the first thing that I thought about was our assessment. I'll have to be honest, I see seasoned nurses doing this as well. Um, you have to look at your patient as a whole. Sometimes they tell you things in your assessment before you even ask. Okay. So I have been around some nurses that they will literally ask every single question on the assessment. To me, I get better results with honey. I like to just sit down and have a conversation with people. I typically have, like, at a certain point in time, you will memorize an assessment. You know how to do a review of systems, and you'll just know. You just go head to toe. You'll just remember it. And whatever your charting system is, you'll probably end up memorizing it. You don't have to, like, is that page 3? No, you know that's page 3, like, or whatever it is. And so that really opens you up to kind of sit back and just talk with them, and you're not looking at a computer or you're not charting, you're actually making eye contact. And, you don't have to ask them, how is your gait? You see them walking, you know how their gait is. If people, like, even with home health and stuff, if you take jobs in home health or hospice where you're going into the home and you see that they live on the 2nd or 3rd floor, they have to climb the stairs. That. So work smarter and not harder. This is not to cut corners. We're not cutting corners. Do your assessment, but you don't have to be redundant. And I remember being a new grad and patients saying, you already asked me that question. It's like, well, I did. I'm sorry. I'm trying to get through this assessment. Yes. But think of ways that you can work smarter and not harder. So you're not having to be there hours after clinic doing things that you could have been doing, at other times. Anything there, Liz?
Well, yeah, it just makes me think also of, like, I would agonize over writing my notes, because you go from writing these paper notes that are like, that you submit as a paper, they're like 25 pages, right? As a SOAP note, and then you have to write 10 of those a day, like that. And so I'd agonize over them. And so I think one of the things that really helped me, and if you have the time when you're first starting and you see one patient per hour, I would take the full hour, because it was a hard first year for me. I just took my time. I had a lot of learning to do. But if you have time and you don't take your full hour with every single patient, making those quick texts or smart phrases, however your EHR does that, and having a Word document you copy and paste, like common conditions like diabetes and hypertension and dizziness and headache and asthma, and like all the common HPI questions, at least. Because, like, for me, not only would that help with my charting, but it would help trigger the questions that I needed to ask, especially when it came to dizziness and headaches and those kind of like scarier complaints. But yeah, it's the smart kind of like time-saving things, absolutely, too.
Yes. And just adding on to what you said, going to my next point, common is common. So when you have those common diagnoses, and you will know what they are, they come in every single day. You're going to have a ton. I mean, when the seasons change, you're going to have your bronchitis. Your kids are going to have the ear infections. You're going to have your H&Ps. Those things are going to walk through your doors all the time. Save yourself some time. Make your templates. You know what I'm saying? If you know what your treatment is, if you have a medication that you will have a repertoire of medicines that you like to use, and there's a lot of antibiotics. We all like certain antibiotics over certain people. I mean, we all do. Yeah. Outside of the guidelines, you'll get a list of things you can start, and we all have a go-to medication. If you know that, when this child comes in with this acute otitis. This is what I'm going to use. Yes. And then if that doesn't work, if they can't do the amoxicillin, I'm going to do this, or,
Totally.
go ahead and make like when you have that free time, go ahead and make your care plan as a template so you can go in and edit it
Absolutely.
when there's any variation,
I love that tip.
My preceptor had over 20 years experience, always used templates for charting.
Oh, I still do. Absolutely.
Yes, where you have time, and because you'll get in there and you'll say, okay, all right, yeast infection. Like, I know what I'm going to use, and I know how to send it.
Yes.
Make your template.
Yeah, and I think it's like my students definitely come to me with like, I know the first line treatment because that's kind of what they cover in school, but like that's part of your real world exposure is that like, oh, we're going to do amoxicillin. Oh, you have an amoxicillin allergy. What do I do next? And like that is definitely like a common process of like each thing that you're like, every time you have that new tidbit of knowledge, like capturing it somewhere, whether it's in those quick texts or I love that template. I don't use as many care plan templates. I think just because the EHR that I use is not as conducive to that, but it's so helpful. Even if you just want to list it out as like amoxicillin, like or like PenVK, 500 milligrams BID times 10 days is the first line, and then the next line is this, and so they're all written there, like PenVK and whatever comes next, and so that like, you can just erase the ones you're not using, just so it's there. But yeah, having all those reminders, so you don't have to use your brain as much because you think a lot.
And just to know, like, I don't know if y'all's professors ever use this, but my professor said, like, you're not going to see a lot of zebras. Yeah. You're just not going to see a lot of zebras, meaning that you're
tempted to find them. I thought I found pancreatic cancer like all the time. Never was.
Yeah, well, the thing is, you're not going to get a lot of left field diagnosis. You're going to get them. They're going to come through where you have to dig. But when you get them, you'll never forget them. You'll never forget them. But common is common. Like you're going to see it, and that's one of the reasons why I wanted to shake up being in primary care, because where I saw the same thing all the time and I was getting bored. Like I was like, I have to kind of I got to get some fresh air and get out and stuff like that. And let's see, we said, okay, any resources to use to prepare for practicum. I started in the fall and want to prepare this summer. Now, let's clarify. When you say practicum, are you talking about your clinicals? Because I know some people use different terms. If you can clear, yes, okay. One of the things that I would say, the advice that was given to me, make the most of that time. That is your training. Basically, go in there and be a sponge. Take you a notebook little notepad that you can keep in your pocket, in your lab coat pocket. Ask a ton of questions. They're going to teach you, just like the other person said that their precepting physician said, like, you're here to learn. They know that you're here to learn. And so learn, the difference between being a registered nurse and a nurse practitioner is that when you're a registered nurse, you have like 8 weeks, 12 weeks as a new grad RN. You have like a week or two, okay, as a nurse practitioner. You will probably start seeing patients the first week. You may have a very low census. If you have a very gracious clinic that you work for, they may let you shadow a day, but that's probably also a day or two to let you get up on the computer.
Yeah.
They are paying you to see patients, so they're going to push you out quick. Okay. So your clinicals, they're your training. So what you can do, you're going to learn what you need to learn in clinicals. Like I enjoyed my clinicals. I had an awesome time in clinicals. I only had one clinical experience that was a dud for me. And it was actually probably, if he was a nurse practitioner, he pawned me off on his brand new grad nurse practitioner, and he took all the credit hours. He didn't even give them to her. And she's the one that trained me. She had literally been a nurse practitioner for 6 months.
Ouch.
And so that was the only one that was a dud, but everybody else, it was great. And I just went in, and whatever they told me to do, I did it. And I did it.
Yeah. And I think it depends. I don't know if you said it was the first practicum or not, But like,
Yeah.
I think that the thing that I see, and I think it's just because nurse practitioners just typically have they're so ambitious and they have such big hearts and they're so smart. And like, I think the general like mindset that I see a lot is like, I got to do this right now. I need to do this yesterday. And like, I think my personal perspective on students, and it depends on the preceptor that you have, but like the first chunk of your clinical hours is history and physical. And
Yep.
like, as you progress in your program, you will get to make your plan of care. Because I remember being so frustrated that our first differential diagnosis in class was like allergic rhinitis. And I was like, seriously, you gave us like the most boring thing to talk about. I want to diagnose like the fun stuff, you know? But yeah, so like, just like try not to be beating yourself up about you not being there yet. Because I think that's like the trend from the beginning of school all the way to new grad is like, that's like the main mindset I really want to encourage for people to think about is like, give yourself a break. It's okay. You're going to learn it, and you're going to learn way faster than you could ever imagine.
Yeah.
The beginning of my clinical experience to the end, I was like, oh my gosh, I did not imagine I would ever be this far. And then when you start in your new grad job, you get the same amount of clinical hours in the first like 3 months of working that you got in your entire program. So it's like you're going to learn so much so fast, and just have the patience and, you know, just ease on yourself that like it'll all fall into place. Like just show up, be attentive. That's it. That's all you got to do.
Yeah.
Show up and try to see patients, and be like lower your expectations a little bit, because I think I have so many perfectionist students that are just like, I missed that question and I didn't ask it. Like, it's fine.
Yeah.
It's fine. Like, this is what I expect from you, and this is what you expect of yourself. Like, you're going to forget stuff, right? If you just go in with that expectation of like, you're going to forget questions, you're going to get nervous, you're going to forget to look at someone's ears. Like, it's okay.
Yeah.
We're all learning, right?
Like everybody's gonna be fine.
Right.
I don't know how people's clinicals are set up now, but how they did ours. We had to do acute, and then we did our specialty, which was we did like, you know, peds, we did our women's health, and then we ended with chronic management, and which was really good because by that time I was basically seeing all the patients and just reporting back to my preceptor at that time, you know, where they were holding my hand at the beginning. But by the time I got ready to graduate, it was like, I'm ready to graduate. I'm ready to get in the clinic.
Yeah.
So you know, wherever you're at, whatever the clinical is, just be there. Like if the focus is peds, just do your peds. You know what I'm saying? Like be in it, be in the moment, and just learn that. Carolyn asked, do we have an example of a care plan template that either would like to show? I personally don't have a care plan because I have been on a lot of different charting systems, and depending on what the charting system is your care, is your care plan.
Yeah, I was gonna say I have a couple of templates of like quick text that I have of the HPI, and I can look at that link, and I can send you that link, Kim, if you want. And then the other thing is like I could just write one up. I'd be happy to, like an Amoxis or like a otitis media or something like that, like kind of an example of what we're talking about.
Okay, and this says, how do you feel about charting in the room while you're with your patients? I know it depends on how many patients you see, but sometimes charting in the room seems so impersonal. There is a finesse with it. I have gotten really good at knowing how to write while looking at people. And sometimes you're just not going to get it right. Some people want your full attention, and some people feel like if you're not looking down at the computer that you're not doing work. Like
you're not writing it down, right? You're like, are you writing this?
Are you listening to me?
That's how I feel. Like, right away, it's fine.
Like I'm like, okay, you know. So I have gotten into a habit of I'm really good at being able to write and just a quick like glance, and that goes to like pretty much like memorizing your charting system, where you know, like I know where to click. Like I look, and there we go. You know what I'm saying? I do chart in front of my patients, and I follow up after. Like when I get out, I finish up the longhand stuff afterwards. But I will make myself quick notes of like, you know, make like a mental note to myself, like go back and address this system. You know, I picked up something on this system. If everything else was good, then it was just normal, you know. But if it's, you know, if I pick up something, if I need to do a referral, I'll make a quick note for myself, and I'll just even tell them, because people will get to talking, you know, and you just say, give me a moment, you know, just give me a second, and let me write this down, because I don't want to miss what you're saying, you know, because it's the truth. And so a lot of people, I've not had any issues with that, you know. I've not had any issues with that. Have you?
No, no. And I was going to say, I think two things that come to mind from my personal experience was, one is that I would write it on a piece of paper and then I would do my notes later. And I got so inundated with trying to do my notes after work, and it was too much. And so I basically just got to the point of like, I have to write my HPI. And I think the other thing is that as I developed in my practice and I came up with the chief complaint of like X, like headaches, for example, I knew the questions to ask. And so I would document the questions as I asked them. And then the other thing that's really nice about having the computer in the room is that I would look things up constantly. I would not know what to do. Someone would be in front of me with a chief complaint I'd never seen before, and some eye-related problem, and I'd pull up to date at the same time, and I'd be like, okay, so here are the questions I want to ask you. You know, like, do you wear contacts? Like, I can't even remember the example, but I have this picture in my mind of one of the people I was precepting, like doing the same thing of just literally looking it up to date and then asking those questions, and that's really helpful to have. And people don't necessarily need to know that you are doing that, and that's okay.
Yeah, and I think too, as new grads, we can think that we have to know it all. I mean, seasoned nurses don't know it all. They don't.
Mm-mm.
And then you throw in the fact that you may be treating a different demographic than you're used to, or you're in a specialty or something like that. Like, I have literally whipped out my phone and just said, well, let me look that up for you, because that's how comfortable I am.
Do.
Like, I don't
know.
have any shame doing that, because if anybody in their right mind thinks like, nobody thinks that. Like, even your patients, they know you don't know everything. And I mean, now there are some things that it's like, okay, you probably do need to know how to do some things, but like, if they ask you like an off the wall question, you're like, well, I never heard of that. Let me look that up. You know what I'm saying?
That's
and that
hard to say at first, but yeah.
Yeah, like they may, it's really not as big as we make it in our heads. It really isn't. It really isn't.
And like, I think I totally agree with that. And I think that like most people just feel that you care and that you have a heart and that you're listening to them. And like, people honestly say that to me. I'm like, oh no, I don't care at all. Like, do whatever you need to do. Like, you actually listen to me, you know? And like, the other thing is like, sometimes people, I've had a couple experiences where people just assume that I know things. Like, I don't think that they know what doctors know. I don't think what they know what NPs know or PAs. Like, I think that some people assume, like, at least family members and friends sometimes would come to me with questions, and I'd be like, do you know what I know? Like, so
Yeah.
that's hard, especially if you're brand new and you feel like you should know those things, versus like you and I, like, have had a couple of years, or like many years of experience where like we're okay with saying that because we feel comfortable saying that. So it's like, it's the same situation. We just feel more comfortable saying we don't know, you know?
Man, and so yeah, we're gonna keep it real. We're gonna keep it real, because I've actually seen that backfire on people when they come off like they do know everything. I remember one of my teachers saying that's the most dangerous provider you can be, is to act like you know everything. Like, we're supposed to always be students. That's part of being in science. It's always changing. It's always evolving. There's always updates. That's one of the reasons why, like, I went into diabetes, and I really started to, like, that's how I even started, because like, I felt like I couldn't keep up with all of the updates and all of the standards of care and who's sending down these guidelines. And I had been a nurse practitioner for like 5 years. And so I went on a personal journey just to make myself a knowledgeable nurse practitioner, and realized, wow, this is actually interesting. And that's where it clicked for me. And so, and even with diabetes, I don't know everything. I still have my point people that I go to. I love having an endocrinologist in my back pocket, okay? Because we don't know everything, and they're changing stuff all the time. New advances are coming out. And so there's no way, okay?
And if they have a problem with you for not knowing something, that's fine. Like, you don't, like, no one's gonna no one it was going to be liked by everybody. Like, it's fine. They're just not for you. You're not for them. They're not for you.
Yeah.
It's fine.
Yes. Now, I don't have any more like clinical pearls, but I see somebody said, let's open up a can of worms of salary negotiation. Oh, I can talk on that, but I'm not going to keep you guys all night long. Do you have anything before we dive into that and allow others? Y'all can go ahead and start putting your questions here and we can knock them out.
Yeah, no, I think that sounds great. I think that sounds awesome.
Okay, this was. Oh, I'm happy that this is what I wanted it to lift people's anxieties. Okay, so salary negotiations. So this is another mind shift, guys. As registered nurses, we don't really negotiate. You don't. You fall in a category. This is what the 0 to 5 year RN gets. That's what you're going to get. That's the highest you're going to get. With nurse practitioners, you're a provider now. Okay, so that means that it's more than compensation. It's about your time. It's a lot of things. All of these things, your insurance. You know, the first NP job that I had, because my husband, it was cheaper for him because he worked at a corporation, so their insurance was better. It was cheaper, and I worked at a mom and pop clinic, and theirs was so expensive. I negotiated to not take the insurance, but them to give me that money on my salary.
Good for you.
That's what I decided to do.
Awesome.
And so that, so those are, you can have those talks back and forth. You're going to probably be signing a contract. You should be signing a contract. Liz mentioned a nurse practitioner friend of ours, Amanda, who does the Resume RX, and she goes a lot into negotiations as well. But one of my biggest things that I tell everybody is to have your deal breakers and don't go past that. Like, if you know you're not going to want to take call, don't bend on that. Don't do it. Don't say, well, I kind of can take call. It's not going to work.
Yes, and you're going to do it.
Yes. At any point in time, if they say we need everybody to take call a couple of more days, you have to do it. And so I knew I had a child and I have a husband, and I didn't want to work on the weekends, and I did not want to do call. That was one of the reasons why I left the bedside, and I knew that. So I did not ask for that. I had a job to ask what I round at the nursing homes. I worked in nurse practitioner school in nursing homes, and I knew that I did not want to do that. I hated that. And now I bless everybody who does that, but I did not want to do that, particularly because I knew that the physicians dumped on the nurse practitioners. I did not want to do that as a new nurse practitioner. So my answer was no. You can negotiate all that and put those in your terms in your contract. So,
and I think it depends on like the type of clinic that you're working in too. So if you're in an independent private practice, it's a little different than if you're in a hospital system that has like stricter rules, or like a community health center that has like just like, again, like stricter rules and like funding. Like, again, it comes down to like, do they have the position, they have the money to hire you? And I definitely, like, I had a very liberating experience where I kind of was like, I went into my current job search being like, I'm not gonna allow myself to accept a job that I'm not happy with. Like, not that I haven't been happy with my other jobs, but there were just some things that I didn't negotiate before. And I think coming into this, I just was like, okay, so I'm just going to walk away, which is terrifying, right? When you get a job offer and you're like, I have to take this. And I just was like, no, I'm not going to take something that I'm not happy with. I'm not going to take under this amount of money. I'm not going to take this qualification, and it's a little bit trickier when you're brand new and you don't necessarily have like the experience with having negotiated before and like the leverage and understanding what all the components are. So it is kind of like a longer discussion, but yeah, I think never, a book that I'm interested in reading if I ever change clinics again is Never Split the Difference. And so if you have some downtime, I've heard of this as a great negotiating.
I'm in the midst of it now. It's a great book.
Oh, cool. Awesome. My last boss told me to read it before I got my new job, and I didn't. I should have, but I still ended up with a pretty good contract. So.
Now, it says, my preceptor told me to always sign a contract with a productivity bonus plus salary, never sign just the salary. Do you agree? You want to go with that one first? Oh, I'm sorry, Angela. I missed yours. We'll come back and get yours, Angela, after this. I'm sorry.
Yeah, so we don't do like RVUs, which is like the terminology for it. We just don't do it at my job. I didn't ask for one. I guess I could have. If I see a certain number of patients per year, I'd get a certain sum of money. Like I've seen that at other jobs, even community health centers, of like $1,500 if you see like X number of patients in a certain amount of time. I am not interested in having that hanging over my head.
Mhm.
I'd rather see less patients and with higher quality care. Like I feel like
Mhm.
that puts an added pressure on me. So it's really kind of up to you and up to the culture too, I think, of the
Mhm.
clinic and the expectations. You just have to get a good feel for it.
Yes, you really got to listen. You got to read the terms, because I have seen it worded in a way where you would never get that
Yeah.
productivity bonus.
Yeah, you never get the
And
bonus, or you have to meet a certain really high productivity
yes,
consistently as a general practice. So you're seeing 30 patients a day, like just being really careful about that too. Like
yes.
that's
Now I'm going to go back. Sarah asked, ethics for treating friends and family. I am very skittish of this. I do not treat friends and family. I
never,
do not.
don't do it. I've gotten
And I
suckered
have,
in and I regret every single time it's happened. Don't do it.
yeah, I do not see friends and family. Um, this is what I have been told by physicians and nurse practitioners. That's just what I've been told. Also, I know a girl that I went to undergrad with that is currently um, in court for treating and writing narcotics for family members. And so it's a quick way for them to flag you.
Yeah.
Okay. And once you get flagged, it's kind of like the light bulb is on you now. So
Mm.
you just need to protect your
The
license
DEA is what
with
you're
your
saying.
life. Okay. With your life.
And also, like, I think the reason that I give for my friends and family who ask me are that like my objectivity drops completely. I have no objectivity when it comes to my family member. I assume that they have cancer. I assume they have a brain tumor. I assume they're going to die. Like it's just not. I'm not a good clinician. My brain it doesn't work anymore. So that's not safe care for them, and I don't feel good about it. So.
So, what is a fair orientation period at a new job? A few days, a week? What is the average? You want to take that one, Liz?
I mean, I think that like it really depends on what orientation means. And so I got 2 weeks of shadowing and I misunderstood and I thought it was going to be a couple months. But I think what you had said earlier about the fact that like we are revenue generating clinicians, like people like that, like they rely on us to support the business is like we are the major income for the entire organization, us seeing
Mm.
patients, like at least 70%, at least at most clinics. So I shadowed for 2 weeks and then I started seeing one patient per hour. And I should have written this down because I have a foggy memory of how long it lasted. It lasted a lot. They were very, very generous with mine. It took about a full year to get to full schedule, but like full schedule, which is about 20 patients per day, was about like, between 6 months and a year. But it really depends. It's kind of all over the place, I think. What is your
Mm.
experience so far with that?
Uh, well, it's been kind of different in that you can negotiate that too.
Yeah.
How much? I did have a clinic to ask me how much time I needed, and when you get that question there, I do think that I don't believe that you should be shadowing as a nurse practitioner. I think you are prepared to see patients. I think that you should have a way to work yourself up,
Mm-hmm.
and maybe having a schedule how you can work yourself up to when you get to the full amount of patients. And every clinic is different. Like the first clinic that I worked at, they wanted me to do almost 40 patients ultimately. And even seasoned nurses, it was a horrible job, guys. It was horrible. Okay, I've gone through the school of hard knocks. The physician was horrible. He's in jail now. He is in jail. So it was horrible. Okay, so I have stories for days. But I never got to 40. I think a good place for me was like 25. And then depending on what I was seeing, I could get up to 30. But when I started having like longer types of visits and things like that, it was just, you can't effectively do that. You can't. But a good place for me was anywhere between like 18 to 25, where I felt like I was like really like I knew everybody was what they were doing and
Yeah.
everything like that.
And that's usually in the contract too, of like what the expectation is of how many patients per day.
Yeah. And it says, how do you feel about getting DNP? Do you think it will be a necessity in the near future? Well,
I feel like they were talking about it being required when I went to school like 5 years
yeah,
ago.
they did say it was going
So
to be
that's why I
required.
like skirted in with my MSN, and I was like, I'll just get grandfathered in. It'll be fine. So
Yeah,
like I
so
just didn't want to go to DNP at the time because first of all, they didn't have any programs where I was living, and I felt like I don't feel like I understand the full value of it. I actually was just talking with somebody today about this, is like if I want to teach in the university setting, I will do that. But like in clinical practice, I don't think I fully understand if it will help my clinical practice, but I also don't feel like I understand it that well. But it's hard to know. I mean, I think the advantages that I saw before is if you have more clinical practice hours, but I think it depends on the program if you get more clinical hours or if you just spend more time doing research. So it's really hard to say.
hmm and you got to think too of your goals. Okay. It's, you can have a goal. You can have goals as a nurse and a nurse practitioner. Um, I do not believe, I believe that eventually it probably will be like a necessity. I don't know when, just like having your bachelor's degree, like you're hardly going to see a lot of associate programs now because a lot of the hospitals wanted magnet status, and you can only get there when you have a bachelor's degree. And so they were requiring that, you know what I'm saying? And I think eventually it will probably be, maybe, but for me, I don't personally want a DNP. I would, to be honest, if I was going to do something like that, I would go to med school. I would. Like for that type of money to still have restrictions, that's just my opinion, and the goals that I have, I don't need a DMP, there's certifications that you can get, like, someone said something about derm, you can get certified to do stuff like that. You don't have to do a DMP and go through a whole program again, but if that is what you want, do it. That if that's what you want, do it. It's just not something that I feel like at this time, I don't see the difference in what it would make in what I do now. That's it. Unless I wanted to teach, which I don't want to teach out of college. Not now. That's just my opinion. And then the website, $10 Tuesdays. Yes, it's on the NPACE. What were some of the NP groups? Some of the big wigs in the nurse practitioner have some good groups. Barbara C. Phillips has one, and she's great. She's all about nurse practitioners becoming entrepreneurs and owning businesses. She has a podcast, and she has a nurse practitioner business owner.
Oh, I don't know that one. I should be.
Yes, her name is Barbara C. Phillips. I met her at AAMP. She's wonderful. She has a lot of information, as far as, because she's actually opened clinics and she sold clinics. So she knows all of that. She knows about social media marketing and stuff like that. There's family. I'm a family nurse practitioner, so there's family nurse practitioner networking group, that I think that's what it's called. That one is managed by Charmaine Lawson, who is a big wig as well. She's a fellow. She was big with Katrina. She has a cartoon. She has books, nurse practitioner cartoon books, kid books, called Nola the Nurse, that talks about nurse practitioners during Hurricane Katrina. Yes, that's how she became a fellow. I mean, like big wigs, y'all, like trailblazers. And so she has one. She manages one. Of course, I think that same one. I think Amelie is in there from APEA. Also, Miss Margaret Fitzgerald. They're in that group too, and they're admins. So that's a big group. It's like 30,000. Okay. And then if you just Google groups, nurse practitioner, if you're wanting to go into there's a group that's for DNP groups, like DNPs. There's a group for nurse practitioners that want to bridge into MDs or DOs. There's a group for that. There's a new grad. There's one called APRN New Grad, I want to say. There was but they're all public. If you just put in nurse practitioner, a ton will pop up.
I'm so glad you mentioned those, because I thought I was in all of them, but I haven't heard of. Oh, I haven't heard of the APRN and then the business ones. I'll definitely check those out. There's NP guidance too, and nurse practitioner newbies, I think, and there's a whole bunch of them. I mean, I think that if you're not in them currently, I just like maybe a little bit of, I just keeping in mind that sometimes people can not be very nice because they feel frustrated, and
Yep.
I don't know. I don't want to be disparaging at all, and I think there's a lot of supportive, really nice people as well.
There
But just,
is.
I think that some people feel a little discouraged when they hear a lot of negativity. So it just depends. It depends on the culture of the individual Facebook groups that you find.
Mhm.
That's all I'm going to say about that. But
Yes. Yeah, I know what you're talking about.
I'm glad that we take a stand for such positivity.
Yes, yes. And there's a lot. There's a lot of nurse practitioners in there. They will answer your questions, no problems at all. But there's always bad apples everywhere. And y'all know the saying, there's nurses that eat their young. They're still there, you know, and you know, I'm normally very vocal in those groups because I don't like bullying. I do not like nursing bullying at all. And I don't pick a fight with the little kid. Pick a fight with with me, you know, because that's how I am, you know, because a lot of times people do that because they know that they can intimidate people, but they don't do that to the people that they feel are peers. And so, you know, I make it very known. I've been a nurse practitioner for a while, so you can talk to me. So let's see. Okay, I find myself struggling with medication costs, knowing who I can prescribe what to. And do you have a quick resource for formularies? I find some patients take it personally if you prescribe a medication and they can't. Yep, they will. You prescribed me a medication, it costs $500. For example, I find myself shying away from prescribing. Oh, yes, because I've learned, yes. So GLP-1s are great medications, but they are expensive. And that's just that's where we're at. So you're going to have to prescribe. Like one of the things that I did, I found the insurances that I typically saw, you know, that were common in Texas and stuff like that with my demographic, and I pulled their formularies, and I made sure that my MA pulled it so I would know. There at the time, I don't really know if they do this too often, but the $4 list.
I was just going to say that, yeah. And GoodRx too. I don't use that, but my colleague is obsessed with it. GoodRx.com. I don't know how.
But it's not for Medicare and Medicaid. That's the only thing. It's for commercial, and I saw all Medicare and Medicaid, and so so you do have to, and that's going to be one of your frustrations as a nurse practitioner, is trying to find medication that I know this is going to work. Why don't you pay for it? I know this is the test that they need. Why won't you pay for that? You know, this kind of comes with it.
And also, like, I still rely heavily on my pharmacist. We have a pharmacy associated with my clinic, and I just would call Yelena all the time at my first job. And I'd just be like, what alternatives do you recommend? And they just run their insurance, be like, oh, okay, so this one's $500 and this one is $5. So, and sometimes like my father-in-law was using a topical medication, and it's like just the potency of the medication of like 0.5 versus 0.25 was $500 versus $10, right? So like there's these little tweaks, and you kind of learn as you go, and it's not personal, but it's frustrating. So I just encourage patients to call back and like just don't not pick up your medication because it's too expensive. Just let us know. You know, it's hard to know.
And then I think we have one more question. I'll take this question and maybe one or two more if you guys have anything. How important is LinkedIn to your professional practice? Do you use LinkedIn?
I have a profile.
I do too.
I don't know. It's hard to know if anyone's reaching out or not. I don't know. I have a lot of like kind of like random reach outs, but it's not really like, I don't know. I think they're like, I don't know if they're recruiters. I don't know. It's very, I haven't used it a ton, but I think I've heard a lot of people who have success with it. So it's hard to know. Have you used it or for job search?
I have, but I have not seen it give me more leads than like Indeed or Monster or anything. I actually probably got better leads on Indeed. But LinkedIn is changing. LinkedIn is like Facebook was like 5 years ago. So it's like Facebook for the professional, you know? Yeah. So it would not hurt to have a profile. But you have to be on there. You know what I'm saying? Like be on there. And, you know, Angela said that she's got a ton of job offers from LinkedIn. I found several preceptors. So yes, when I came along to find a job, I mean, it was just like anything else for me. But now LinkedIn is like, it's literally like Facebook.
I know, it's kind of weird. But yeah, I mean, totally. Like it's hard to know with our industry, but it's definitely like a thing, you know, for most industries.
And it says, as a new grad, how do you choose an MD to refer patients to? I don't know who accepts what insurances. Is that something I will learn as I go, or should I just create a list? You can do both during your clinicals. You can do both. Yeah. You, again, knowing the insurances that you treat, they can send you a list of people in your area. Also, you can get the profile, the directory, and stuff like that. And I just mentioned this on one of the videos that I put out, I think on Saturday, about networking events. Go to workshops and lunch and learns in your area, because once you get your license, everybody has your NPI. And they'll start sending you invitations to the local, like these farm companies will like want you to come out to look at their new medicine, and people will go. You'll get a free meal. You know, they'll wine and dine you, you know, and you learn something, but other people are there, and you can start learning about people in your area. You can just call people, you know, just like you just start calling, hey, and when you find a good fit, then you keep them, and they refer to you. They can refer to you too. You know, Absolutely. If somebody's looking for a new PCP, you know, well, they can refer back to you. You know, how do you go about it, Liz?
Yeah, so I would say that a lot of offices have a referrals pool, like that they already refer to, because based on the insurances that they accept. And so definitely, like you kind of saw, and also when you get your referrals back, when you get your consult notes on your desktop, when you enter into your new job, like you're going to see consult notes on patients that are assigned to you. You've never met them before, and you still have to review them. So you'll actually like get to see the same names over and over again. And then like over time, I am such a huge fan of cold calling, and maybe people are sick of hearing me say that, but I just love it. It's so scary, but like I would just pick up the phone and I'd call them and be like, okay, so is this an appropriate referral based on this information? And then you get to a sense of like who's really nice, who's really helpful. And I'd get personal cell phone numbers of like nephrologists, and like they're like keep me on the phone for like half an hour, like chatting, like I have some patients, but thank you. But he's super nice, right? So yeah, I think a lot of offices like already know, and some offices do the referrals for you. So I have a referrals department. You place a referral order, they make the appointment, they send the letter to the patient, and you're not even involved. So and you can request specific hospitals or specific places, but you have to figure it out for you.
That's a good way Cindy, that's a good way that you found a preceptor. She Googled specialty offices and found NPs, and then found them on LinkedIn.
Oh, that's private message. That's crafty. Nice work. That's awesome. I've had a couple of people actually reach out on LinkedIn, and I'm already like associated with a school, so I couldn't take them, but I admire that. And like that makes a big impression, because like you're willing to do all that work and show all that effort.
Okay. And we'll take this last question. Does it just take time to develop the preferences for medications? You want to take that one first?
Yeah, I mean, I think it comes down to largely what's covered by insurance, and then what the guidelines show and what the allergies are. Sanford Guide is an amazing resource for antibiotics specifically. But yeah, I mean, diabetes is my main challenge because it's not covered by insurance. So everyone's on metformin and like some sort of insulin. Sometimes it's NPH, and you're like, it's not really what I want to be using, but that's what's covered. So I think it's just time, and then whatever guidelines you can follow, and then just trying until you see what can work for you.
Yes, and I second that. It does take time. I did come out of clinicals having some medications that I liked. If I had a preceptor that I felt like when I was doing peds, like he was like a Doogie Howser. Like he knew everything, you know what I'm saying? And he graduated.
My colleagues right now, I just like want all of his knowledge.
Yeah, like he graduated med school like super early, and like he literally was a Doogie Howser, and he would not let me use a calculator to like do my calculations. He was like, "You can do it in your head," and I was like, "I need to check," and he was like, "You're smart enough to do it." And so he would like, but he was so nice. He was English, and it was great. We were a hoot. And I trusted his preferences, and I saw, he would tell me why he would pick medications, and it made sense. And so I came out of clinicals using those medicines, you know what I'm saying? Because he saw kids so much, he wasn't a big fan of amoxicillin. He would do it, but so many kids were tapped out on amoxicillin, so he would do Omnicell. Right. And he went down all this right. Like the reason by it being because it will cover this, it's gram nick. He would say all these different things. Might be like, oh, okay, and I'm not there yet. That makes sense. I'm gonna write that down and look that up later.
And like those are other awesome points too. Like with the amoxicillin, like tastes like bubblegum, and like the other ones don't taste as good. And so if you have a really young kid, like it's nice to use the bubblegum one versus like Bactrim, for example. Every time someone's on an ACE inhibitor and I try to do Bactrim for UTI, it has hyperkalemia is one of the side effects. And so it's like, you just learn that because like you try to prescribe and the EHR is like, please don't do that. And you're like, oh, again, and like you kind of just like, and then like the other thing I think about is like ease of dosing, right? And so penicillin, like PenVK is like BID dosing versus like, I hate Keflex because it's 4 times a day for like a skin infection, right? But it's like the first line, and so can I do Bactrim? But then they're on an ACE inhibitor, so you kind of just like have to just figure it out and like just you'll remember that each time you have to make that decision, right? So ease of dosing is huge.
And it sounds like it's very confusing, but like you will retain so much of what does not work, and it's not like a life or death situation unless you do an allergy. You always need to check your allergies. But outside of that, I mean, real talk, like you'll remember that, you know what I'm saying? And especially if it's a medication that you will be using a lot.
Right. And that Bactrim and ACE inhibitor thing is only because I've tried to do it 1,000 times, like 1,000 times, and it still pops up and I'm like, okay, fine, I won't do it this time. So don't worry about those. Your EHR is really helpful, and your pharmacist is really helpful too.
Yes. Well, Liz, I think we are done, and I want to thank all of you guys for coming on and spending about an hour with us. And I hope you all got some information out of this. I hope it was helpful and that you got your questions answered. And so before we leave, Liz, do you want to tell them where they can find you? And I'll tell you guys where you can find me.
Yeah, so I am on Instagram, Facebook, YouTube at Real World NP. So all those things with Real World NP at the end. And it's also at realworldnp.com. I also have an ultimate resource guide for new NP. It's realworldnp.com/guide. Would be the easiest way to grab that. Couple other resources, but yeah, on YouTube I feel like is probably the easiest one. But any of those work. Yes, and I could do the guide one.
Yes, and you guys can find me on YouTube. Go and subscribe to all of our things.
Oh yes.
The Diabetes MP, and actually here in a little bit I'll be coming out with more resources for you guys. And so just if you make sure that you're on my email list, and you will be able to be the first to know about all of those things. Okay.
Absolutely. And I'm going to make that care plan template. So I'll probably post that on Instagram or on my email list too. So you can get that at realworldnp.com/guide. And those are the weekly emails.
All righty, guys. Thank you all. And we will talk to y'all later. Bye.
Thank you so much for having me. Bye, guys.